Welcome back, everybody. It's now my pleasure to introduce the first plenary session of the conference, which is presented by the Chair of the Independent Hospital Pricing Authority Board, Mr. David Tune. Before his appointment as the Chair of IHPA in February this year, David held the position of Chair of the Aged Care Sector Committee, which provided advice to the Commonwealth Government on aged care. David's also undertaken many reviews for the Commonwealth and state governments, including the legislative review of aged care in 2016. He co-chaired the independent review of parliamentary entitlements for the Commonwealth Government and the independent review of the NDIS. David was the Secretary of the Commonwealth Department of Finance from 2009 to 2014, where he's responsible for advising government on all budget issues. Prior to that, he worked in a range of government agencies, including the Treasury and the Department of Prime Minister and Cabinet. 10 years on from the introduction of the National Health Reform Agreement and the establishment of IHPA, David's presentation will reflect on IHPA's achievements over these years, and he will examine the most significant issues facing IHPA now before providing a future view of what is ahead for IHPA over the next 10 years. Unfortunately, David's on a plane and is unable to join us live today. So at the end of his presentation, I'll be answering any questions you might have. So please pop them in the Q&A box as we go. I hope you enjoy the presentation.
Hello, everyone. I'd like to welcome you to the IHPA ABF conference for 2022. Late last year, IHPA celebrated its 10th anniversary. It's been in existence for 10 years now. And I'd like to run through this presentation, some of the achievements that have been made in that 10-year period, as well as looking into the future agenda for IHPA. But before I do that, I'd like to pay tribute to my predecessor, Shane Solomon, who led the board of IHPA for the first 10 years of its existence, and along with fellow board members, past and present, as well as the staff of the organisation, have done a fantastic job in that 10-year period. So thanks very much to Shane and all the others involved. With reflecting on IHPA's first 10 years. As most people know, the Independent Hospital Pricing Authority was established in 2011 as a result of the National Health Reform Agreement that was signed by First Ministers in August 2011. The agreement set up an activity-based funding model to provide a basis for more efficient use of taxpayer funding of hospitals, and secondly, for increased transparency in the use of those funds. As I said, the agreement provided for the establishment of IHPA to independently set the efficient price for activity-based funded public hospital services, known as the National Efficient Price, and any loadings to account for variations in those costs. IHPA was also tasked with determining the criteria for defining block-funded services and the National Efficient Cost of block-funded hospitals. The first National Efficient Price was established and released in 2012. A year later, the second National Efficient Price was released, and the first National Efficient Cost for block-funded hospitals was released. During this time, IHPA also commenced a substantial program of work to improve the classifications for admitted acute care and subacute care, and develop brand new classifications for, firstly, emergency care, secondly, mental health care, and third, teaching, training and research. These were extensive multi-year projects, and for some care types, they had not been undertaken successfully anywhere else in the world. So it was a bit of pathfinding work that IHPA was undertaking. Significant work was also undertaken to improve the National Hospital Cost Data collection and associated costing standards, with a number of costing studies undertaken to obtain robust cost data, while the NHCDC was further developed. In April 2016, all Australian governments signed a heads of agreement that committed to improve Australians' health outcomes and decrease avoidable demand for public hospital services through a series of reforms, including the development and implementation of funding and pricing approaches for safety and quality. This led to IHPA being issued a direction to advise the then COAG Health Council on options for a comprehensive and risk-adjusted model to determine how funding and pricing could be used to improve patient outcomes across three key areas. Firstly, sentinel events, secondly, hospital-acquired complications, and third, avoidable hospital readmissions. 2017 saw the introduction of pricing adjustments for the first area, sentinel events, So no Commonwealth funding has been provided for episodes that include sentinel events since 2017. A year later, in 2018, a risk-adjusted pricing model was implemented for the second key area that I mentioned, that being hospital-acquired complications. In 2020, a new model for the national efficient cost was also introduced. This new fixed plus variable model means in calculating the block-funded hospital costs, the fixed component decreases while the variable component increases to reflect increasing volumes of activity. The new model removes the potential financial disincentive when shifting services from an ABF hospital to one that is block-funded. It is also more responsive to changes in activity levels in block-funded hospitals. In 2021, IHPA implemented a risk-adjusted pricing model for the third key area that I mentioned for the health and safety, the safety and quality agenda, that being avoidable hospital readmissions. In addition, IHPA introduced pricing of emergency department care using the Australian Emergency Care Classification for the first time. This represented a significant advancement in the classification and pricing of emergency department care, basing it primarily on patient diagnosis and clinical profile, and reducing the reliance on administrative variables such as discharge status. Okay, so that's the first 10 years, and you can see that a lot has been done by IHPA over that period. But where are we now in 2022? It would be fair to say that this is an extremely challenging time for IHPA. The complexities we are dealing with in developing the NEP are unprecedented. We published the NEP for 22-23 in March this year, and by far the greatest complexity has been trying to account for the impact of COVID-19 and develop a robust pricing model to price public hospital services for the upcoming year when these services are continually evolving due to the pandemic. It is difficult, if not impossible, to predict the volume of hospital activity for 2022-23. Furthermore, hospital costs have changed as a result of COVID-19. In some cases, these costs will not be enduring as the hospital system adapts to dealing with the pandemic, but in other cases, the increased costs will be sustained into the future as they become embedded in health service delivery. Differentiating between these two types of costs is quite challenging, and the significant variation in COVID-19 cases and experience between the states and territories adds a further complexity to the analysis. NEP 22, that's the determination for 22-23, relied on cost data from the 2019-20 financial year, which of course was impacted by COVID-19. IHPA quantified the impact of COVID-19 on both activity and cost data. However, it is not possible for IHPA to definitively account for the ongoing impact COVID may have on service and delivery and costs in 2022-23. Therefore, IHPA has taken the approach of adopting a set of assumptions in the development of NEP 22 that are outlined in detail in the NEP determination itself. This includes assumptions related to hospital activity returning to historical trends and that the increase in costs will continue into 22-23. The determination makes clear that if these assumptions do not eventuate, it may be necessary to review the determination based on updated activity and cost data. IHPA will continue to closely monitor the situation in consultation with jurisdictions. During 22, IHPA will be developing a methodology for assessing COVID-19 impacts on the 2021 activity and cost data, which is the data set that will be used for the NEP determination for 2023-24. The methodology will also include details on IHPA's approach to monitoring the set of assumptions that I just referred to, used in developing NEP 22. There are several areas that IHPA is unable to model at this stage as the data is simply not available yet. For example, changing patient clinical profiles due to long COVID or complications arising from COVID, or possible changes to activity and lengths of stay arising from delayed diagnosis are the sorts of things that we just do not have adequate data on at the moment. We've continually updated our classifications throughout the pandemic to ensure data can be captured relating to COVID-19 diagnosis, associated conditions and vaccinations. While the highest priority for NEP 22 was accounting for the impact of COVID-19, IHPA was still able to deliver another milestone for 22-23, which was the pricing of admitted mental health care using the Australian Mental Health Care Classification for the first time. It has been a 10-year journey to get there, starting with the development of mental health definitions and cost drivers in 2012, a national costing study in 2014, classification development in 2015, commencement of the new classification in 2016, and shadow pricing for 2 years in 2020, 21 and 21, 22. The number of clinicians, consumers, carers, health services and jurisdictions involved in the journey has been extraordinary, and every one of those should share in this achievement. Compared to the current model of pricing admitted mental health care based on the ARDRGs, pricing using the mental health care classification demonstrates a significant improvement in accounting for the increased costs of mental health care type patients. Analysis shows that mental health care episodes are more complex and costly than other admitted acute episodes in the same DRG. Implementation of pricing using the mental health care classification is estimated to result in a 7% increase in modelled costs for mental health care episodes relative to the DRG-based pricing model that was used previously. In addition, IHPA intends to keep progressing towards ABF for community mental health through pricing under the same classification, the Australian Mental Health Care Classification. To date, community care has been a block-funded service, and data collection and quality has been historically far more challenging in the non-admitted area than it is in the admitted area. Nevertheless, the activity and cost data continues to improve, and IHPA has been shadow pricing the Australian Mental Health Care Classification for community mental health in 2021 and 22, and we will be looking at further in fact to assess readiness of ABF for community mental health for 23-24. The last area I want to highlight is the expansion of IHPA's national benchmarking portal, which we are formally launching at this conference. IHPA has had the national benchmarking portal since 2016. It provides access to compare cost and activity data from public hospitals throughout Australia. Access has been available to public hospital managers and clinicians, with access managed by jurisdictions. The Pricing Authority is of the view that open access to data alongside appropriate privacy and security protections can enhance evidence-based policy decisions and improve patient outcomes. The Authority has been driving the expansion of the portal to provide broader public access to hospital activity and cost data. We went live with the portal on 27 April this year, and the first stage of the rollout focuses on providing dashboards on costs per national weighted activity unit. Stage 2 of the rollout, scheduled for later this year, will include dashboards on hospital-acquired complications and avoidable hospital readmissions. The rollout has been accompanied by supporting materials such as a user guide, instructional video and technical supplements. Expansion and increased access to the portal aims to deliver benefits such as more effective research capability, improved policy decisions, better benchmarking against similar health services and improved transparency. There will be a session at the conference this afternoon at 3:15 to formally launch the portal and take people through the various dashboards. Okay, so let's move on to what is coming up in the future. Firstly, to public hospital services and what the pricing and funding models might look like in the future. I don't think there's much doubt that ABF has been an effective funding mechanism since it was introduced to Australian public hospitals in 2012. It has contributed to creating a more equitable and transparent system of hospital funding services across Australia, where the same service receives the same Commonwealth funding. It's also been a key contributor to reducing the rate of growth in public hospital costs over this period, and remains a very effective tool in measuring hospital and health service performance and benchmarking. However, public hospital activity funded solely under ABF has limitations and may not generate the best incentives for certain types of care. For example, episodes of care that span multiple settings, such as joint replacement surgery, requiring acute care, subacute rehabilitation and outpatient care. Or secondly, for frequent users of hospital services, such as those with chronic conditions. ABF will continue to be the best pricing and funding mechanism for many hospital services, particularly where patients receive acute one-off episodes of care. However, there is potential for new pricing and funding models to be better for patients receiving care across multiple settings and for patients with chronic conditions. Some examples of these alternative models include bundled payments and capitation payments. I won't go into the detail of those, but bundled payments are basically payments made to health providers for a clinically defined episode or bundle of related healthcare services. And the main criteria for identifying where bundled payments may be appropriate is a clear, well-defined care pathway that spans multiple care settings or over longer periods. Capitation payments are based on a cost per person funding model that pays the provider or fund holder for the care of a patient for a defined period, where the provider is accountable for the range of services consumed by the patient for that period. For patients with complex and chronic health needs that can lead to frequent use of hospitals, capitation payments may work better. IHPA analysis of these two sorts of alternatives indicates that around 50% of current hospital funding is likely to remain on an ABF basis, with 20% amenable to bundling approaches and 30% likely to be suitable to capitation payments in the future. And we published that analysis in the pricing framework for Australian Public Hospital Services 22-23 for those who'd like to see more detail. The addendum to the National Health Reform Agreement that was signed by all First Ministers in May 2020 provides opportunities for states and territories to trial innovative models of care. The addendum outlines IHPA's role as 1, to develop a funding methodology to support trials of innovative models of care, 2, to advise jurisdictions on the application of the methodology and any issues foreseen with regard to the national model, and 3rd, to advise health ministers on any proposal to translate an innovative funding model to the national funding model. Jurisdictions have been working together to develop principles to support trials of innovative funding models and to guide bilateral agreements between the Commonwealth and individual states or territories for these trials. IHPA continues to engage with jurisdictions to fulfil its role as set down under the addendum and will explore future funding models. The 21-22 federal budget forecast a rather large expansion of IHPA's functions, and that involved, subject to passage of legislation, that the scope of IHPA's role will be expanded to move into aged care pricing advice. The budget announcement specified that in response to the Aged Care Royal Commission, the Australian Government will implement an independent process to advise Government on aged care pricing issues, including under the new Australian National Aged Care Classification funding model, otherwise known as ANAC, the new residential respite funding model, and also home care pricing. So there's 3 aspects there. This will be delivered through an expansion of the current IHPA to be renamed the Independent Hospital and Aged Care Pricing Authority. And as I said, that is subject to legislation that will need to be reintroduced into Parliament after the election. IHPA will inform government decisions on annual funding increases in residential aged care from July 2023, and the activities relating to home care pricing will be established from 1 July 2023 as well. As I said, the legislation is still to pass through Parliament, but in the meantime, IHPA has been working hard in the background, developing a high-level roadmap for the delivery of residential aged care pricing advice from July 2023. It is a fairly massive task, and we've tried to get ahead of the game a bit and get started on working through. First thing we'll need to do is develop an aged care pricing framework, which will be the key policy document that will underpin the approach adopted by the agency in providing aged care pricing advice to the Commonwealth Minister for Health and Aged Care. IHPA is committed to ongoing open and transparent consultation with all stakeholders in the aged care system. Therefore, prior to developing the aged care pricing framework, IHPA will undertake a public consultation to seek views on the pricing principles that will underpin the framework and the key challenges for aged care costing and pricing and how best to address them in the framework. Concurrently with this consultation, IHPA will progress with costing studies to collect activity and cost data to inform the first pricing advice. The first study, the Residential Aged Care Pilot Costing Study, aims to test a number of approaches to collecting cost data and staff activity information from residential aged care facilities. Preparatory work for the pilot study commenced in November last year, though was temporarily suspended in January this year due to the impact on residents and facilities of the most recent COVID-19 outbreaks. IHPA will resume the pilot study as soon as restrictions allow. A second significantly larger costing study is planned later in 2022. This larger study will aim to collect cost data from a wide range of facilities to ensure a representative sample of cost data is collected. This will assist IHPA to more accurately determine differences in costs by facility size, type and location, as well as cost differences associated with specific resident groups and ANIC classes. The process of consultation, policy development and cost data collection will support IHPA in developing an appropriate pricing model for residential aged care to inform pricing advice to government. So as you can see, a lot has been achieved in the first 10 years of IHPA's life, and there's plans for further expansion as we go forward, both in the hospital funding area and also in the aged care area. So there's a lot to be done, so many challenges, but we're looking forward to addressing them. I hope you enjoy the conference today and that over the next 2 days, and that you get lots out of it. So thanks very much.
Very much, David, for that presentation. And as I mentioned earlier, unfortunately, David can't be here today for the Q&A session. However, I'd like to introduce Joanne Fitzgerald, who's IHPA's Executive Director of Policy and Classification, who's going to direct the questions to me. Prior to her role as Executive Director, Joanne was the Director of the ARDRG Development Team and responsible for development managing the ARDRG classification system at IHPA. Jo has more than 15 years experience as a health information manager, 10 of them with IHPA. Has been working in health classifications in both the public and the private sector, and also worked as a clinical coder, manager of clinical record departments, and at the New South Wales Ministry of Health. Thanks, Jo. It seems we had some technical issues there, so I've got an eye on the Q&A session.
Let me try now, James.
Yes.
Okay, thank you, James. So let me just go back to the live Q&A, see if any questions have come through. And we do have our first question. What is the progress for the work on the non-admitted classification system? So an update on where we are with non-admitted classification development.
Yeah, great question. Thanks for that. Unfortunately, the costing study to replace Tier 2, the costing study that would have formed the basis of the classification development, was due to start, or had in fact commenced in March 2020, and obviously that was just as the pandemic kicked off, and unfortunately we had to cancel that costing study. We are right now looking at alternative methods and looking to get that going again, we hope in the next few months. Our intent, if we can, is to take a different approach to this costing study and to try and rely on information in electronic medical records so that we can keep the data impost as low as possible. So yeah, really good question. Stay tuned. I hope that we have some good news on that in the next few months. So I have some other questions here that I will just read out to you. So the first one is, will the innovative models of care that we're considering that David spoke about and looking to pilot with jurisdictions be limited to just hospital-based services? And the answer to that is no. One of the goals of these innovative funding models, particularly the capitation model, would be to allow hospitals to engage a much broader range of services with the intent of trying to reduce the need for admitted services whilst not putting funding at risk. So the idea would be that hospitals would receive the same funding for a patient based on their expected hospital use, but are free to spend that money where they need to purchase services they need. And if that results in less admissions, then the hospital would theoretically make a surplus. So a strong incentive to reduce admissions. But if obviously if those don't work, then the hospital will be responsible for covering any admissions. Another question that was sent through separately, obviously COVID's been a big issue for us, and questions on how will we account for the impacts of delayed care and post-COVID conditions. This is a really live issue for us. The board met with the WA Health Minister on Monday and with the DG, and that was a really key point of discussion. Two parts. One is the delayed care is an issue we all need to watch very carefully, because I don't think any of us really understand what the impact will be and how that will interact with the funding cap. And secondly, in terms of additional COVID costs and long COVID costs, that's one we're keeping a very close eye on, and we'll be watching very carefully. Just having a look for the live Q&A. It's very slow. Oh, sorry, there's more there that I couldn't see. Bronwyn asks, when will the community mental health work be finalised? Another great question. So that work will be is essentially finished and is being shadow funded right now. So those weights are available in the last determination, and we expect that will come into effect from 1 July 2023 is the timeline we're working to. So we know there's a lot of improvement in data going on, and people are working very hard on that, and we look forward to that coming into effect in the next financial year. All right, I apologise for the technical issues there. Poor Jo's very frustrated. I can see her on the screen. And we're now out of time. So I'm going to wrap up that session and invite you to go back to the timeline, fill in the survey, and then come back for the first keynote speaker of the conference with Dr. Amor here. Thanks very much.